All right, so let me share my screen. Okay, welcome to the second part of Summer Syndromes, July 15th. And it is a great pleasure to follow one of my co-fellows, David, and I agree with everything that was said, that for all the fellows out there, that is one of the highest yield talks and disease sets that you will not only need to know for boards, but also for just patient care in general. You will see many patients with those conditions during your training. And to switch gears completely, the list that I will be talking about is disorders of hearing and vision, which on the review course PDF, it looks like more of a potpourri of syndromes that happen to have eye or ear involvement. So what I thought I would do instead is that these are important syndromes and genetic disorders that you should know about. They will tend to be heavy for board fodder, and you may see a couple of patients with these, particularly Hermansky-Pudlak syndrome, as there's, and maybe Usher syndrome, as there are clinical protocols on the NIH campus with these. And so, you should be aware of them, but it's difficult to connect them all. So I thought I would just take a step back for the first half of the hour and just talk about vision and hearing loss, and in particular, looking at these groups of disorders as frameworks for understanding disorders for other systems. So to start with hearing and vision loss, so these are sensory deficits. It's very important to note that for children with hearing and vision loss, that for many of these conditions, they have normal developmental potential and normal intellectual potential, but without intervention from speech therapy, visual aids, physical therapy, occupational therapy, and getting the correct plan for school, they can have developmental delay and even intellectual disability as a result of not having proper interventions, which is, in a sense, iatrogenic and our fault. So for children with hearing and vision loss, I think the biggest take home from a clinical perspective is to make sure that they have the right therapies, the right school plans, and that they have teachers and therapists that will be heavily involved in their care, and that they also get connected to the relative groups for hearing and vision loss in their communities. And though there are a lot of accessibility aids in our society, those do depend on them having other senses. In particular, for hearing loss, a lot of the aids are sight-based, including sign language and certainly Braille is by touch. For vision loss, it's a lot of, again, touch and hearing aids. And so the important thing to note is that patients with deaf-blind disorders are going to have a particularly difficult time with adaptation. And so those patients with Usher syndrome, it's particularly important to intervene early. The other, and I'm going to try and keep my chats up over here. Oh, and David, goodbye. So for these hearing and vision loss syndromes, so the first thing to note is that they have massive locus heterogeneity. And what that means is that there's a lot of overlapping disorders that have many different genetic causes. And so this is in particular for congenital or childhood sensory neural hearing loss, and for retinitis pigmentosa or rod cone degeneration. So for sensory neural hearing loss, of the autosomal recessive disorders, which are denoted DF and B by the locus, there are 115 of these in OMIM. For dominant or DFNA, there's 77, and for X-linked DFNX, there are 7. Also note that in the hearing loss community, there is a lot of intermarriage, and occasionally two parents with the same genetic cause of their hearing loss get married and have children, regardless of the situation. And if they both have a dominant form in the same gene, they can have a child with a much more severe form or even a syndromic form as some of these autosomal dominant forms, these DFNAs, also have semi-dominant, more severe, or even syndromic forms. For the vision loss community, that is a little bit less frequent. There tend to be more intermarriages between sighted and normally sighted and not normally sighted individuals. And but for retinitis pigmentosa, there are 89 loci of autosomal dominant, recessive, or semi-dominant forms in OMIM currently. So these are also relatively common hereditary diseases. So you will probably see patients with one of these, even though they're not in our list, except for the Connexin 26 as one of them. But for deafness, there's the prevalence is roughly 1 in 1,000 to 1 in 2,000. And so if you have an infant with a severe to profound hearing loss on a newborn screen, there's about a 50% chance that that's genetic. And if it is a genetic form, there's a 20% chance among those 50% that it is a syndromic form of hearing loss. Likewise, for retinitis pigmentosa, if there is vision loss in infancy, and the very severe form is Leber congenital amaurosis, where sight is lost in the first year of life, there's a 30% chance of this being syndromic. And retinitis pigmentosa is a little bit less common, 1 in 2,000 to 1 in 3,000 prevalence. But again, since we'll go through the list of diseases at the end, but I wanted to talk a little bit about thinking about organ-based diseases and thinking about the entire organ in order to understand these the cluster of disorders that affect its development or its maturation or its normal functioning. I won't go through the ear just for the sake of time, but I will go through that for the eye. So for visual perception and loss, so the eye is the light sensing organ of the body, as we know, and light passes through the clear cornea anterior segment with the aqueous humor, the lens, and this is focused on the back of the eye at the fovea. And the light is transmitted by electrical signal from the retina to the optic nerve. The retina is a very sensitive and specific organ, in that you have point-to-point resolution of what's going on in the outside world to what's being transmitted to the brain. So this is the optic nerve, this yellow disc, as we'll see in other pictures. These are the blood vessels. And then this area where there are the endpoints of blood vessels, but no blood vessels crossing, this is the macula. So this is where our 20/20 central vision is, roughly the central 20 degrees of vision. And so this is what puts things in our center field into focus, like these young boys with these balls, and then the periphery tends to be more out of focus. But if you have a lesion in a particular area of the retina, it's very readily reflected by what the patient is able to see. So even though we don't get training in dilated eye exams typically to use all of the different tools that are used in ophthalmology for examination, you can learn a lot from patients just by talking to them, and you can get a sense for what their retina or the front of the eye might look like as a result of their vision experience. And so, for instance, if you have a lesion in the center at the macula here, and this is just positioned the opposite way from the middle panel, then you will have vision loss in the center of the field. But if you have a disease that affects the optic nerve or disease that affects the peripheral retina, then the periphery of your vision will start to decrease and you'll maintain central acuity. And we'll go through these for retinal degeneration, but I want to go through some of the terms that we use in ophthalmology so that you're familiar with them as well. So microphthalmia is a small malformed eye. This is actually a really confusing set of terms because there's nanophthalmia, which you would expect to be an even smaller eye than microphthalmia, but in fact nanophthalmia is a small but normally structured eye. So they have relatively small eye, but still normal anterior and posterior segment structures, whereas microphthalmia is a small eye with multiple malformations, including anterior segment dysgenesis or a small cornea, as you see in this patient. They can even have coloboma, or they can have optic nerve dysgenesis. So again, and these can be asymmetric between patients. This asymmetry in eye size with eye malformations does not necessarily mean that it's not from a monogenic condition. There's also anophthalmia, which is the absence of the eye, which is also somewhat incorrect because the patients most often do have a very, very tiny eye or a very, very tiny remnant of the developmental structures that would have formed the eye. So anophthalmia is maybe the absence of a detectable eye structure. And then there's also cryptophthalmos, which means hidden eye, but that's where the eye is behind a sheet of skin where the eyelids don't form properly. And here are some examples of coloboma. We'll talk a little bit about eye developments in a second, but when we talk about coloboma with patients, we most often think of the so-called keyhole iris, where you have a ventral defect in the iris, so it's not continuous in a circle forming the pupil, but you'll have this ventral defect that is a coloboma. So these colobomas can be of the iris, they can be of, this is the back of the eye again, they can be of the ventral retina, or they can be of the optic nerve, and they could be continuous from iris to nerve or just one of those structures. And the reason comes back to optic vesicle patterning. So during development from the neural tube, we have the extension of the optic vesicles out to each side, as in these two eye fields are formed and separate by the expression and signaling of sonic hedgehog. But these move laterally to contact the surface from the neural tube to contact the surface ectoderm. And this is a close-up of that. And so the sonic hedgehog signaling activates a set of transcription factors, Rx, PAX6, SIX3, OTX2, and LHX2, that contact the surface ectoderm and cause a cascade of other transcription factors. And eventually it sets up several signaling gradients of fibroblast growth factor and bone morphogenetic protein. And we're not going into developmental biology lecture, but I want you to understand that sonic hedgehog as a cause of holoprosencephaly, and these transcription factors are causes of different eye malformations. So if you disrupt any piece of this cascade, you're likely to have a defect in how the eye forms as a result of failure of this optic vesicle to set up a proper signaling cascade with the surface ectoderm. So what happens after the surface ectoderm is sort of activated as this lens placode as it invaginates, and then the optic vesicle also inverts and forms this area in orange will form the neural retina. This area in green and blue will lay down on top of the neural retina and become the retinal pigment epithelium and the optic nerve that's still connected to the brain. This surface ectoderm will pinch off to become the lens. And these different transcription factors, again, if you have changes in PAX6, which you see in the surface ectoderm and in the optic vesicle, you can have a variety of malformations of the anterior segment or the posterior segment with PAX6. MITF is involved in Waardenburg syndrome, which is both hearing loss and retinal and iris hypopigmentation. PAX2 causes papillorenal syndrome. You can see here it's in the optic stalk, so it causes an optic nerve coloboma or morning glory syndrome with renal malformations. And so you can trace back these things from development, and you can do this in many organ systems to understand the cause of disease from the perspective of development. And I hope that you'll have the chance to take Les Bieseker's course on this. So the optic stalk and the optic cup here, they zip up from the ventral side, so this choroidal fissure, through which the hyaloid artery and a vein pass through to provide circulation to the inner surface of the retina and to the developing lens and anterior segment, which then regresses closer to the end of development. But this zipping up, if there's any failure in this, that's why all of those colobomas of the nerve, retina, and iris were on the ventral surface. And so again, here are some of the spectrum of disorders that can cause microphthalmia, anophthalmia, or coloboma. So BMP4, again, that BMP signaling cascade is autosomal recessive, and you have micropenis and renal hypoplasia in addition to these eye malformations. RAX comes with anophthalmia, and you can also have eyelid malformations like ankyloblepharon and cryptophthalmos. SIX3 you'll probably recognize from holoprosencephaly, similar to sonic hedgehog. SOX2 is a very interesting gene, so this can cause an anophthalmia or severe microphthalmia. They also have hypopituitarism and esophageal atresia or tracheoesophageal fistula, which is a really interesting a really interesting differential diagnosis, which you might put with Kabuki syndrome and others. They also have a postnatal microcephaly, so they can be born of normal and a postnatal short stature, so they can be born of normal head size and stature, and growth just appears very slow on from birth. SOX9, you have a campomelic dysplasia, so of the distal extremities. And then those with XY karyotypes have a sex reversal. So patients with SOX9 appear phenotypically female, regardless of karyotype. And then PAC6, you can have any ocular anomaly again. Another important signaling pathway is the vitamin A or retinoic acid pathway. So with eye malformations, you also want to think about vitamin A embryopathy or fetal alcohol syndrome. So both of these are implicated in retinoic acid pathway signaling and can have eye malformations associated. The series of genes in the retinoic acid pathway during eye development that are associated with eye malformations are also associated with congenital diaphragmatic hernia, or CDH. Sorry, I didn't spell that out. Congenital diaphragmatic hernia, which can then lead to pulmonary hypoplasia and early lethality. And so STRA6, retinoic acid receptor beta, ALDH1A3, which is an enzyme that breaks down retinol, and then RBP4, which is a serum protein that carries retinol from the liver to the eye and brings it to the STRA6 receptor, where it's internalized by RARB and then cleaved by ALDH1A3. Moving now to the anterior segment. So patients may be described as having aniridia or absence of the iris. And so these patients can have a stump of iris or a completely absent iris on slit lamp examination. There's also congenital cataracts here, which you'll see with the white pupil, which of course always think about other things such as retinoblastoma until you get a really good eye exam. But upon slit lamp exam, it's very clear that these are based in the lens. Peters anomaly is a very interesting malformation. So again, when the lens invaginates from the surface ectoderm, if it doesn't completely pinch off, it leaves a connection between the cornea and the lens, and that impairs the ability of both to become clear. And so here you can see on this white spot in the patient's cornea here, and then on cross-section, gross histology or gross cross-section, you can see that connection between the cornea and then the cataract that formed in the lens. And again, just to remind you that of two things, that this is because of the way that the lens is invaginating from the surface, and it has to pinch off in order to separate and then eventually become clear for light to pass through. And then secondly, just to bring back, yet again, the PAC6 can be involved in any ocular malformation as it's expressed in the surface ectoderm and the neural retina in the lens during many stages of development. So now moving to other anterior segment malformations. So Axenfeld-Rieger syndrome is one that you'll see. Most likely this is autosomal dominant, most commonly associated with PIDX2 and FOXC1 as a causative genes. Posterior embryotoxin. Sorry, my arrows are crossed a little bit here. Posterior embryotoxin is the Axenfeld anomaly. And it's a forward displacement of Schwalbe's line, which is a line between where the clear cornea comes to the white sclera here and lies right at the ciliary body, which makes the aqueous humor sitting right behind that. And then a chorictopia, which is the Rieger anomaly, is a malformation of the iris that causes it to be displaced and misshapen. These patients also can have adhesions between the cornea and the iris called iridogoniodystegenesis, which can lead to glaucoma, which will cause irreversible blindness if the retina and optic nerve degenerate as a result. They can also have dental hypoplasia. And then the classic sign is failure of involution of the periumbilical skin. So they'll look like they have extra folds of umbilical skin in patients with Axenfeld-Rieger syndrome. Next, just to talk a little bit about some of the other features you might see in the iris. Normally, I would have folks call these out. I'm not sure exactly how to manage this, but you did see in Ben's talk last week on clinical examination, you talked a lot about these anyway, and everyone got the right answer. So again, these are, here are Lisch nodules associated with neurofibromatosis type 1. These here are brush field spots associated with Down syndrome. Sorry, I should not have called that trisomy 21 since I cannot see their chromosomes. This is heterochromia associated with Waardenburg syndrome. These are the starburst irides associated with Williams syndrome, which are not often this striking. And then this is anisocoria, which is actually relatively common, and this happens to be a picture of David Bowie. But anisocoria is an asymmetry in the dilation of the pupil, but pupils are otherwise normally formed. The important thing too is that there's again a lot of locus heterogeneity and variable expressivity for these anterior segment dysgeneses. So this is a list of some of the genes associated with anterior segment dysgenesis, and then here are some of the different anterior segment malformations, and then some of the malformations that have been published with each of these genes. And I just put X's here for multiple times because you can often find a case report or two to support some of these other ones. Okay, and finally to move to the back of the eye before we switch gears and talk more about the syndromes on the list, to talk about retinal development and function. And so this is again the optic vesicle coming out from the neural tube, and then the invagination of the lens. The retina then proliferates and gets thicker, and different cell types start to differentiate. First, the ganglion cells, which form the optic nerve, and then the photoreceptors, and then the interneurons. And what you end up with is a three-layered structure. And on the innermost side of the retina, so the first layer of cells that the light passes through are the ganglion cells, and this is the ganglion cell layer. And then there's an internuclear layer composed of interneurons, including bipolar cells, amacrine interneurons, and horizontal interneurons. And then the outermost layers are the photoreceptors, or the rods and cones that detect light and transmit that information through the ganglion cells to the brain. And on the outside, just outside of the photoreceptors, are the retinal pigment epithelium. And so again, light strikes the photoreceptors, and this information is then translated into electrical signal to the bipolar cells, to the ganglion cells, and back to the brain. So you will see patients, especially when you're on your NEI rotation, and in general practice, you will probably be referred patients with retinal degeneration. So again, retinitis pigmentosa, about 1 in 2,000 to 3,000. And again, you can tell, even if you can't decipher all of the ophthalmologist's notes and acronyms and everything, or if they haven't seen the ophthalmologist yet, you can glean a lot of information from talking to the patient and getting a good history. So these are the sort of signs and symptoms that can help you define a diagnosis. So we break down the retinal degenerations into roughly 2 axes. The first is whether they involve the rods or the cone photoreceptors, or both. So the cones detect light and help with color discrimination and provide high acuity vision. And they populate they're most densely populated in the center of the eye in that macula. And so when you have a cone dysfunction disorder, you often have photophobia, or what's more like it's called photophobia, but it should be photodynia because it's a painful response to light. They have color vision deficits, visual acuity loss, so they don't reach 20/20 vision, even with glasses, or scotoma, which is a visual field loss, often in the center. With rod dysfunction, rods populate the periphery of the retina and are most useful for dim light vision. So these patients, if you have a rod dysfunction, they have nyctalopia and peripheral vision loss. But most retinal degenerations, they either progress from a rod-based disease to a cone-based disease, or the reverse. They'll progress from a cone-based disease to a rod-based disease. But understanding which cell type is affected first based on these symptoms can really help you to understand what the causative gene set could be. So again, you can sort of use these as a lesion localization paradigm to try to understand whether the center peripheral retina is affected. The other things to consider are the onset. So different genes or syndromes have onsets in infancy. And again, 30% of children with vision loss during bilateral retinal degeneration in infancy have a syndromic form. But onset can be in infancy, childhood, adolescence, or adulthood, and there are different sets of genes. Of course, there's a lot of overlap between these periods, but you can get a sense of what gene or genes might be the culprit based on onset. And there's also, you want to understand whether this is a static vision loss or if it's progressive. Most are progressive, but there are a small set where vision loss, even if it occurs in infancy, does not progress or get worse. And this is most typically achromatopsia, which affects cones more, or congenital stationary night blindness, which affects bipolar cells, but it tends to cause more of a night blindness phenotype. And so inheritance, again, for retinal degenerations can be anything, but again, this can help you to narrow down your gene or genes. And just to note that even though you can get a lot out of your exam, there's also a lot of variable expressivity, incomplete penetrance, locus and allelic heterogeneity. And while there are some genotype-phenotype correlations, sometimes even within the same family, you can get a wide spectrum of disease. So again, this is just a list of the progressive disorders: Leber congenital amaurosis, retinitis pigmentosa, Stargardt disease, which tends to affect the macula, cone rod degeneration, and enhanced S-cone syndrome, and then the stationary type, achromatopsia, cone dystrophy, and congenital stationary eye blindness. So retinitis pigmentosa, again here, affects 1 in 2 to 3,000. The rods are affected first. I'm just including these slides in case folks are interested, but I'll go through them pretty quickly. But we'd already mentioned that there are over 90 genes associated with this condition. Stargardt disease affects roughly 1 in 8 to 10,000. This is a juvenile onset macular degeneration that affects the center retina. So these patients tend to have a central scotoma and central acuity loss, but it is very slowly progressive. Again, Leber congenital amaurosis, it's less common to have the retinal degeneration occurring in infancy. But you really want to be, and I'll say it again, and sorry to repeat myself so many times, but you really do want to try to get a great exam, a full evaluation. About 30% of these patients may have syndromes, and these are typically ciliopathies that you'll learn a lot more about during the rest of the training. I'm always happy to talk to you more about that. But one of the signs when children have vision loss in the first year of life is nystagmus. So it's often a visual deprivation nystagmus. As the eyes are developing, if they aren't able to focus properly due to vision loss or due to other things, the eyes will start to shake and in a pretty typical nystagmic pattern. And then there's also the oculodigital signs. So children will rub their eyes if they're not able to see, and it's been well documented that about 30% of children with LCA will rub their eyes, and parents will even report this when they come in to see you. So the other interesting thing about these, going back to how genes and biology can help us understand disease, is that most of these disease genes affect every aspect of the photoreceptor RPE segment that's involved with vision and translation of light into electrical signals to be sent to the brain. So they can be involved with development like transcription factors like RDX, or formation of the inner segment or of the outer segment that is a specialized cilium. And then there's also an enzymatic pathway that recycles the vitamin A analogs, the retinol analogs, that maintain the ability for opsins to transduce that light into electrical activity, and that enzymatic pathway is recycled through the retinal pigment epithelium. So two things I want you to just take away from this about photoreceptor dystrophies or retinitis pigmentosa, retinal degenerations, just all of the degenerative conditions of the eye that we'll see on the NEI rotation, is that these are inborn errors. Many of these are inborn errors of metabolism. So this is the pathway where light is incident upon opsin. It changes this vitamin A analog 11-cis retinal from cis to trans, and that releases the energy that will be activate the second messenger system to create an axon potential to then go to the bipolar cells. And then this all trans retinal is then recycled through, it's carried up to the RPE, and it's converted back by a series of enzymes to 11-cis retinal, where it's then returned back to the photoreceptors. And every single one of these components has been associated with a different retinal degeneration. So, even though, this sort of looks like the urea cycle or how we process fatty acids, this is another example of how enzymatic pathways in disease are really important to understand, not just for the cause of disease, but they can also help you to remember all the different genes that might be associated with those particular conditions. The other thing to take home is that photoreceptor dystrophies are ciliopathies. So the outer segment of the photoreceptor is a very refined cilia, and many of the ciliopathies have a retinal degeneration component. And many of the non-syndromic retinal degenerations affect the formation of the cilia. Okay, so now just to switch back to the different disorders of hearing and vision. So the first one on the list is Blepharophimosis, ptosis, and epicanthus inversus. So again, this is sort of a potpourri, so I don't know how to create a good thread to go through these, but I'm posting, so you have these slides. I'm going to post from the PDF file onto the slide, but then I'll have another slide where I sort of break things down into what I think are high yield for the board exams. So what are Blepharophimosis, ptosis, and epicanthus inversus? So first of all, this is pictures of two individuals with BPES. So blepharophimosis is a narrowing of the palpebral fissures. So normally as Cedric went over this morning, there's a set of measurements that are very important to know, and it's very important to do measurements to understand if a patient really does have a narrowing of the vertical opening between the two eyelids. So blepharophimosis is a narrowing of this opening. Ptosis is a drooping of the eyelids, which also can lead to blepharophimosis. Epicanthus inversus is a lateral displacement of the lower lid, and so you'll have a little crease like this, and there's also it can be a lateral displacement of the inferior punctum through which the tears drain, so they can also have lacrimal duct issues. And then another part of this syndrome that's not in the name is telecanthus, and this is a widening of the inner canthal distances. And so as Cedric pointed out this morning, and again, I would go back to reference the talk, and we'll talk more about it later. When you're doing these measurements, you really want to understand that these are the inner canthi. So there's an inner intercanthal distance from here to here. And with this, then you can have telecanthus. There is an interpupillary distance from pupil to pupil. And if that is wide, then you have hypertelorism. And hypertelorism is a physical distancing of the physical orbit, so that you have the pupils are actually displaced. But if you have telecanthus, but you have a normal interpupillary distance, it's called pseudostrabismus, but it can also be pseudo-hypertelorism. And that makes it look like the patient is crossing their eyes, but it's really because this area of skin is just very, very broad. And then there's also measurements for the length of the palpebral fissure. And so in say Kabuki syndrome, you'll have a long palpebral fissure. It can be, and this is the inner canthi and the outer canthi, and you can measure this distance. And if that's long, then you would have a long palpebral fissure. So on all these slides too, I posted the gene reviews link, and I would go and read the gene reviews on these as well. So in any case, so BPES is this complex eyelid malformation, and it can be with or without premature ovarian failure. And so if you have premature ovarian failure, that's type 1, and if you don't, that's type 2. So this is management is by ophthalmology and reproductive endocrinology. So hormone replacement therapy can be helpful for this condition. And in patients with POF, you can have high FSH and LH and low, yes. And so Les has a comment to double down on terminology, intercanthal distance, but interpupillary distance, the preferred term is widely spaced eyes and not hypertelorism. Simple is always better. Yes, I would completely agree with that. And so in POF, but in these patients as well on pelvic ultrasound, they may have hypoplastic uterus and hypoplastic or shriek ovaries on ultrasound, in which case there may not be options for improving fertility. And so there are also isolated or non-syndromic premature ovarian failure has also been reported. But again, I just want to note that these patients have normal development, intelligence, hearing, and vision, and I'll post that on a few other slides that just to, again, reinforce that even if patients have or at risk for having hearing or vision loss, it's important to intervene in order to preserve their development and intelligence. Patients with this condition can have vision loss if not managed appropriately. And so you can see that in the panel B, this young person actually has their head tilted up, and that's so that they can put their pupil into the space between their eyelids. Whereas this person here, the top of the pupil is actually, the top of the pupil is occluded by the upper eyelid. And so this can actually lead to amblyopia and peripheral vision loss that's permanent because our vision is developing in the first 6 years of life. So if you aren't intervening appropriately, eyelids being over any portion of the pupil can cause a permanent vision loss because the brain never learns how to interpret data from that part of the retina because it's occluded. This is an autosomal dominant disorder associated with FOXL2 variants, and these tend to be loss of function, 50% are de novo. For autosomal dominant loss of function or truncating variants, it is always a good idea to think that there might be a microdeletion syndrome associated or a contiguous gene deletion syndrome, including that gene. And so 3q23 microdeletion is associated with VPES with additional features such as intellectual disability. And these tend to be fully penetrant, but there have been reports of a type 1 and then isolated PF in different individuals in the same family. There's an important differential diagnosis of congenital ptosis. I would add Noonan syndrome to most differential diagnoses. I think last week, I believe it was Ben who mentioned Williams syndrome being one that's very recognizable but important not to miss. I would say Noonan syndrome is another one of those. It's actually extremely common. It's slightly less common than Down syndrome, but it is common, highly variable in families, and very easy to miss. I had seen a couple of patients. One was a child in residency. One was a child who had a cystic hygroma, and prenatally the child was born. We saw the child. We sent the testing for Noonan syndrome. Mom got out of recovery, came over, and I was struck because she had very clearly had Noonan syndrome, short stature, wet-necked, very classic features, and so that was a really striking example. But I had another patient that I'll admit I completely missed. The patient had craniosynostosis and was in the cardiac ICU for septal hypertrophy, but had a very complex craniosynostosis. So we were thinking all along the patterns of FGF and SCI and some of these other genes associated with cranial malformations. And then, of course, the patient who had the septal hypertrophy, we were completely focused on the craniosynostosis, but septal hypertrophy is so typical for Noonan syndrome that we were sort of thinking Noonan as an afterthought and just on the differential. And the cardiologist said, yeah, just send the Noonan panel too with all this. And we were like, okay, sure, we'll see how this sorts out. And of course, it was Noonan syndrome at the end, but we were so distracted by some of the stronger features that, but I would just say really no Noonan syndrome. Realize it's on the differential for many of your conditions, and it's common enough that you will see it, and if you're not thinking about it, you will miss it. Also, odial blepharophimosis, 3MC, Smith, Lambie-Elvis, and Dubowitz, more from the site of ptosis and blepharophimosis. There is a small genotype-phenotype correlation. So this is FOXL1, so of course it's a fork head transcription factor. And so missense alleles in the fork head domain are associated with type 1. And then there are polyalanine expansions in this polyalanine domain that are associated more with type 2. Remember, that's without premature ovarian failure. Next, moving on to congenital hearing loss. So this is Connexin 26 and 30. So this is a non-syndromic sensory neural hearing loss typically. And so again, and GJB2 is the more common compared to GJB6. But GJB2 and GJB6 are both associated with autosomal recessive or autosomal dominant forms of sensory neural hearing loss, but they're also associated with several dermatologic syndromes also. So keratosis, ichthyosis, deafness, Bow-Winkle or Bart-Pumphrey for GJB2, ectodermal dysplasia, and Clouston type of ectodermal dysplasia with GJB6. So this may be, you may or may not see patients with this, but these could well be on boards. They also, again, normal development in intelligence if properly intervened for development and school. There was a few papers in literature about the potential for a digenic GJB2 and GJB6 with GJB6 deletions, but it turns out these deletions also reduce expression of GJB2, so the disease does seem to still be autosomal recessive GJB2 that happens to have haploinsufficiency of GJB6, but still does not appear to be digenic, but the jury may still be out on that. So loss of function alleles in these genes tend to be more severe. So for GJB2, the patients who have truncating over truncating, so nonsense splice frame shift, do tend to have more profound hearing loss, whereas those with non-truncating alleles tend to be a cluster with milder hearing loss. And I'll show you what that means in a second. Also be aware that the cDNA 35del-G for GJB2 is relatively common. So I just posted the NOMAD v2.1.1 here. And so in Europeans, and on the previous slide, they mentioned different very common alleles in GJB2 for different subpopulations. This allele frequency, as you see, is approaching 1%, so almost a 2% carrier frequency in the non-Finnish European population. And so when we send, genetic testing, we not infrequently find patients who are carriers for this 35del-G in our patients in clinic, and you will probably come across this as well. But just keep in mind that for the 35del-C, for the truncating alleles, they are associated with the recessive and not the dominant form. So the patient would be expected to be a carrier unless you find a second allele or one of those GJB6 deletions. So this is an audiogram, and hopefully you have the chance to see these if you're on the UDP rotation or if we're seeing a patient with Usher syndrome in the NEI clinic. And so the way that these are plotted is on the y-axis by the hearing level in decibels, so loud at the bottom, not loud at the top, quiet. And then the pitch from low to high, so low on the left, high on the right, and that's in hertz. And so patients with normal hearing will have a lower threshold for detecting the sound in any of these frequencies. So those who are detecting the sound at where the sound has to be louder in order to hear at that particular pitch may fall into mild, moderate, moderately severe, severe, or profound. And so that's how those different categories are defined is by the audiogram. The other important thing to note is that some patients can have a hearing loss that's mild at a certain frequency and then profound at a different frequency. So it doesn't have to be mild across the board. So Hermansky-Pudlak syndrome, you will hear many talks about Hermansky-Pudlak syndrome probably in your time here. And I did not do that misspelling at the top. That is straight from the slide, so I'm not getting in trouble for that. So here's the correct spelling, Hermansky-Pudlak syndrome. There's the gene reviews. So this condition has features of oculocutaneous albinism, including hypopigmented hair, skin, iris, and retina. Hypopigmentation of the retina is associated in different forms of albinism with foveal hypoplasia, so the macula where the cones form does not form properly, nystagmus, overdecusation of the optic nerves. These patients have a permanent uncorrectable vision loss even with glasses. Patients with Hermansky-Pudlak syndrome are at risk for pulmonary fibrosis. This can occur in the 3rd to 4th decade and can progress to death. About 15% have a granulomatous colitis. And patients with HPS can have a bleeding diathesis, which is found by prolonged bleeding time, which leads you to think that it's the platelets. And then on EM, they have absent platelet dense bodies, which may pop up on your boards. So autosomal recessive types 1 and 3 are more common in Puerto Rico. So there's a founder allele in the northwest area of the island where about 1 in 1,800 individuals have HPS type 1. And then across Puerto Rico, about 1 in 20,000 have type 3. The others in the differential are the oculocutaneous albinism and ocular albinism without other features. And this is primarily in the pigment biogenesis pathway. There's also Chiari-Higashi syndrome, indicated by the LIST gene, which is associated with infection risk and bleeding diathesis. They have giant intracellular granules and neutrophils. So that would be the other one that on boards may throw you if you're thinking about if they all of a sudden show you a smear or an EM, but I'll show you those in a second. There's also risk for lymphohistiocytosis, and the bone marrow transplant can be curative for those patients. Gracilli is another one with lymphohistiocytosis, and they can also have immunodeficiency. These are often described on your boards as silvery gray hair. I'm not sure if I could tell that apart from the other hypopigmented hair types. And for Ehlers-Danlos syndrome, which is probably also GS1, as there's variants in the same gene, MYO5A, these patients have seizures, ataxia, and spasticity. There's also a newer form of albinism reported by UD and UDP last year by Bill Gall and his group, May Malakdan, with organomegaly, short stature, developmental delay, and including here because these patients, or one of the patients in that study, had hearing loss. Here are the absence of the dense bodies, also known as the delta granules, on EM here, so a normal versus a patient with Hermansky-Pudlak syndrome. And then here are the neutrophil with giant granules found in Chiari-Higashi syndrome. So something like this could be on your board exam or in-house examinations. Jervell and Lange-Nielsen syndrome is an important one to know. These are patients with congenital profound sensory neural hearing loss and long QTC. So on an electrocardiogram, the QRS complex is followed by repolarization of the T wave. And if that time is extended under times of stress, this can lead to tachyarrhythmias like ventricular tachycardia, ventricular fibrillation, torsade de pointe, but these can lead to death. And so this is a very important one to know. And 50%, and this isn't, if you're in the emergency room, you get an EKG, and of course, the patient has a slightly prolonged QT, and you're like, all right, we got to call cardiology before they can go home or make sure they have follow-up. This is much more in your face. So these are 50% have cardiac events before age 3. They need to be treated by beta blockers or implantable cardioverter defibrillator. And this can lead to death by age 15 in up to 50%. They can also have an iron deficiency anemia or elevated gastrin, again, normal intelligence and development. And so these are the calcium channel genes that are associated with this condition, KCNQ1 being the more prevalent. And again, it's autosomal recessive, typically loss of function variant. So, and just to note, this prevalence is 1 in 200,000. So if you have patients with congenital profound sensory neural hearing loss, it's about 1% of those patients could have Jervell and Lange-Nielsen syndrome. So it's just something to really keep on your differential when you're seeing a patient, when you're seeing a baby with profound sensory neural hearing loss who appears non-syndromic. This could certainly be something to be having in the back of your mind and wanting to get that EKG. Leber hereditary optic neuropathy is a form of optic neuropathy, which you see here. So this is a swollen degenerating nerve here. You can also see some tortuosity of the vessels here. And so this is a pretty typical picture of Leber hereditary optic neuropathy. Often the nerve is described as blurry. These patients have neurological symptoms. They have postural tremor, peripheral neuropathy, and abnormal EKG with a pre-excitation pattern. So only a few patients have these extra ocular neurologic symptoms, but it is something to keep on your differential. Something to keep in your mind when you're seeing patients with Leber hereditary optic neuropathy is to consider whether they have extraocular neurological symptoms. These patients also have a mitochondrial inheritance pattern. there could have been a board or in-house testing exam question. It kind of blurs for me, but know that it's complex 1, and that there are 3 common mitochondrial gene variants associated with LHON. There's a pretty big differential for optic atrophies. I think Leber hereditary optic neuropathy is distinguished by a really an acute or subacute onset of vision loss that comes with this blurry nerve. So they'll have normal vision and then all of a sudden a subacute vision loss, whereas the other optic atrophies tend to be much more slowly progressive, like OPA1 or OPA3, which is also 3-methylglutaconic aciduria, and some others that also have extraocular neurological signs that are listed there. Next up is Pendred syndrome. So Pendred syndrome is a severe and profound congenital sensory neural hearing loss with vestibular dysfunction. And so one important one that you may also be thrown on boards is the enlarged vestibular aqueduct with cochlear hypoplasia. Those 2 things together, along with temporal bone abnormalities, is the Mondini abnormality. And so you want to keep the Mondini abnormality in mind, but also know that Mondini abnormality is enlarged vestibular aqueduct with cochlear hypoplasia. You can diagnose this with a thin cut temporal bone CT. So Pendred syndrome is a enlarged vestibular aqueduct with a thyroid goiter. And so this is in about 50 to 70% of patients. They're typically euthyroid, so they have normal thyroid hormone levels, but it should be followed. It can get progressively larger. Again, normal developments and intelligence, even despite having hearing loss, which should be managed. And these are due to changes in the solute carrier SLC26A4, which is a chloride iodide exchanger, explaining how you get to the goiter. So it's about 90% of cases. So also things to consider of deafness with a Mondini abnormality. So besides non-syndromic sensorineural hearing loss, but if you have this Mondini abnormality on your thin cut temporal bone CT, you may be more considering Pendred or the non-syndromic enlarged vestibular aqueduct. Also Charge syndrome. So one of the inner ear abnormalities with Charge syndrome very much resembles a Mondini abnormality. There's also Klippel-Feil or Wilderwank syndrome, which has a fused cervical, which in addition to Mondini abnormality has fused cervical vertebrae and facial asymmetry. Branchio-otorenal syndrome with the IO1 gene, has sensorineural hearing loss, branchial arch cysts, and renal hypoplasia. And then DeGeorge syndrome, mainly because DeGeorge syndrome can have everything, is aortic arch defect, sinus aplasia, developmental delay, intellectual disability, and et cetera. DeGeorge syndrome has a very wide range of common and rare manifestations. So, and inner ear malformations are one of those. Also sclerocornea, so they can have a completely white cornea in about 1 in 200 patients with 22q11.2 deletion syndrome. Would you still call it non-syndromic if Mondini abnormality is part of the phenotype? So non-syndromic in that case, if it's an enlarged vestibular aqueduct with cochlear hypoplasia and temporal bone abnormality, I think you could call that an isolated or non-syndromic Mondini abnormality if they did not have a goiter. I think that would be fair. If anyone else wants to weigh in, please do. And then here are CT images for your use. Usher syndrome, there are 3 types of Usher syndrome. So Usher syndrome is a retinal degeneration with hearing loss. So there are 3 types. So the first is a congenital profound hearing loss and balance issues with a childhood onset retinitis pigmentosa. Type 2 is a less severe form of type 1 in a sense. So it's severe but not profound hearing loss. And the RP is in late childhood or adolescent onset. Type 3 is sort of the kind of the odd type of the 3. So this is a progressive. So the others are fairly stationary in large part because they're so severe. But this is a progressive hearing loss after infancy, which distinguishes it from the other 2. And they have variable onset balance issues and RP. Again, these patients have normal development and intelligence. Myo7A is the most common gene for type 1. USH2A is the most common for type 2. And there's, again, a broad differential that you should know, including Alström syndrome, which is a ciliopathy with obesity, a really interesting transient cardiomyopathy in infancy or adolescence, renal failure, and they can have systemic fibrosis. Alport syndrome, they have variable ocular anomalies, including optic nerve, and they can have progressive renal failure. Wolfram syndrome is optic atrophy, diabetes insipidus, and diabetes mellitus. Heimler syndrome is a mild form, in a sense. It's a later onset, very mild form of the from the genes that also cause Zellweger syndrome. So these are patients who have a hearing loss, retinitis pigmentosa, and amelogenesis imperfecta. And then there's also different forms of atypical Usher syndrome. And then the top, you should always keep in mind that because these are so common, so again, non-syndromic RP, 1 in 2,000 to 1 in 3,000, or non-syndromic sensorineural hearing loss, 1 in 1,000 to 2,000. So that puts you in the ballpark of back of the envelope math is 1 in 2 to 6 million will have a co-occurring monogenic RP with monogenic sensorineural hearing loss. And then here's the picture of the Usher complex in inner ear hair cells to see that in the inner ear here on cross section, the kinocilium and then these specialized cilia on the ends of the hair cells. So as the endolymph moves and transmits vibration to these cells to then translate them into electrical activity, these Usher proteins are important for the connection between the kinocilium and these different hair cell extensions. And then finally, the last one for Waardenburg syndrome. So Waardenburg syndrome is a combination of hearing loss with dermatologic and hair abnormalities. So these patients have a sensorineural hearing loss. They can have a white forelock or piebaldism, which can be a white forelock, or it can be an area of hypopigmentation of skin, or they can have early hair graying. From an ophthalmologic standpoint, they can have heterochromia, they may or may not, and they can also have retinal hypopigmentation of the pigment epithelium or of the choroidal melanocytes behind the retina. In certain patients, they can have dystopia canthorum, which is a very specific measurement that I'll talk about in a second. But this is only for type 1 and for type 3, mainly for those patients with Waardenburg syndrome related to PAX3. They tend to have more of the dystopia canthorum. So there is type 1 or type 3 are caused by PAX3. So type 3 can have limb hypoplasia, carpal fusion, and syndactyly. So if you have limb or extremity anomalies with hearing loss and a white forelock, think type 3 and PAX3. And then patients can also have, in type 4, they can have Hirschsprung disease. And so again, these are all due to neural crest migration defects. And so these are the genes associated with these. These are mostly autosomal dominant, but they're also, again, because patients who are both have hearing impairments. It's a very, very strong community, and so they may have children together. So there are case reports of individuals who have had a child with biallelic pathogenic variants in PAX3, SOX10, and MITF. Of those three, only MITF have been viable, and those patients have an extreme hypopigmentation. They have osteopetrosis, and they also have anophthalmia. And so these are some of the different clinical findings and the percentages between type 1 and type 2. And then as promised, here again, these are the different measurements that you can take to make a W index measurement by this equation here, if you would so choose. I have done this twice in my lifetime. And A here is the inner intercanthal distance, B is the interpupillary distance, and C is the inter-outer canthal distance. And so you apply these three measurements to this formula, and if your W index is greater than 1.95, then they have Waardenburg syndrome type 1 or 3, but usually PAX3. And then again, these are neurocrestopathies, so all the genes associated with Waardenburg syndrome are involved in neural crest migration and differentiation. I'll just place these here. So, sorry, I took a little bit longer than an hour, but I'm still done before the the slotted end to the time. So we'll take any questions, and thank you for your patience.
Thank you, Rob. That was fantastic. Questions? Looks like there's a slew of them on there, but they've already been addressed.
Rob, this is Dee. Quick question. Can congenital nystagmus ever be normal in little babies or prematurity or anything like that?
Yeah, so normal's a tough word for that. So I wouldn't say that nystagmus is ever normal, but you can, so it's certainly a sign that would make you think about, that would make you concerned that the patient does not have, that the patient could have things that could lead to vision loss. So I'd say nystagmus though can be isolated, and it can be benign in the sense that there are some patients who have congenital nystagmus, and there's one gene that has really, really low yield for congenital nystagmus, NYX, and, or not NYX, oh, now I'm blanking on that. I will look it up while I'm answering your question. But there are patients who have congenital nystagmus, and it can be stationary into adulthood, and they have 20/20 vision. They can play sports and everything else. So I would say it's not normal, but it can be benign. And that is FRMD7.
Okay.
It's excellent congenital nystagmus.
Hi, Rob. This is Mickey. I think you mentioned enhanced S-cone syndrome at some point. Talking about the retina. What's that about? I don't think I've heard that before.
Yeah. So enhanced S-cone syndrome is a very it has a retinal phenotype that is distinct from some of the other retinitis pigmentosa. So instead of having, it's a little bit of semantics. So it's due to mutation or pathogenic variants in the NRL or NR2E3 gene, which are critical transcription factors for the specification of rod photoreceptors. So if you're lacking that input, you end up with, so photoreceptor progenitors have this fork between rods and cones, and NRL and NR2E3 push them to be rods. So if you don't have them, you have more S-cones. And so it got the name enhanced S-cone syndrome, not as much because the patients do have an increase in the S-cone syndrome, but it was mainly because the genes were found before the disease was found, and these had been studied in mice extensively. And these mice, when you knock these genes out, have an increase in S-cones. And so when they found the disease gene in patients, it was sort of immediately, even though it looks a lot like retinitis pigmentosa, and there's some really subtle differences, it got named enhanced S-cone syndrome instead of retinitis pigmentosa type 28 or whatever it would have been at the time. But it does have some interesting pigment patterns that I'm happy to talk about. But it's not particularly easy to say that's completely different than RP.
So it's more of like a rod type of dystrophy than in that case?
Yeah, so they do end up with more, so they have fewer rods. So they're sort of born with a rod dystrophy in the sense that their rod input is low developmentally. And then these cones, at least based on the mouse models, the human, there hasn't been extensive human pathology on this, but the going theory is that the S cones that are formed as a result of not specifying enough rods undergo degeneration, and that's the source of the retinal dystrophy. But again, you don't see a lot of like abnormal retinal lamination or other developmental defects. So it really behaves a lot like a rod cone degeneration or retinitis pigmentosa.
Interesting. Thanks.
Sure.
Hi, Rob. Cedric here.
Hey, Cedric.
Yes, Rob. Please. When you talked about the white index in Waardenburg syndrome, type 1 and 3. Is it for calculation of? Is it to find out if the patient has a dystopia cantorum?
Yes, that's the use of the W index. If it's greater than 1.95, then that's considered that's sort of the threshold for dystopia canthorum.
It's a little bit confusing because in element of morphology, dystopia canthorum is described as a synonym of telecanthus.
That's a good point. And it may just be more splitting rather than lumping, because as the W index was, and going back to Les's point, is it maybe just better to say widely spaced eyes versus telecanthus versus hypertelorism versus, it's, I don't know exactly how to answer the question other than it's different than telecanthus in the sense that the nasal root is so broad and prominent, but there may be other craniofacial differences in these patients that give that slightly different appearance. So I'd say dystopia canthorum appears different than telecanthus, but in terms of the W index measurements, I don't know whether or not it's going to be different than the telecanthus threshold, or if the telecanthus patients with telecanthus are also going to have a high W index.
Okay.
But it's a great question.
Yeah. Thank you. Thank you.
Sure.
Can any of our fellows, new incoming fellows, define for us what autosomal dominant means? A lot of speakers, both speakers have used that term today, and it's probably a term we should all be pretty comfortable with and precise about using. So it'd be great if any of the incoming fellows could hazard a shot at what the definition of that is.
Sure, I can take a shot at it. So it's a condition in which inheritance of a single allele is sufficient for full manifestation of the phenotype. So I think one of the contrasts and what we've talked a lot about today is in contrast with semi-dominant, which is almost all human diseases, where you can have the disease from inheriting one allele, but you can get a more severe phenotype if you have biallelic variants.
Right. Anyone else want to amend that or endorse that, new fellows? So probably what you want to do is recognize that, well, let me ask you a question, Thomas. So is HBOC breast cancer, is that autosomal dominant, or is that dominant or is that recessive?
I would call I would say the risk for breast cancer is dominantly inherited, but on a cellular level, the cancer development is recessive.
Exactly. And so what the terms autosomal dominant and autosomal recessive refer to are inheritance patterns, and those terms are not descriptors of diseases. So diseases do not have the attribute of being autosomal dominant. It is the inheritance pattern of a disease that has the attribute of being autosomal dominant, which helps you with that, what you just said about HBOC, right? Because it's the inheritance is dominant, the disease is biologically recessive. And the formal definition of an autosomal dominant inheritance pattern is the inheritance pattern that results if the condition is such that the phenotype of heterozygotes is indistinguishable from homozygous mutants. And the definition of recessive is the inheritance pattern that results if a disorder has the attribute that the phenotype of heterozygotes is indistinguishable from wild type homozygotes. And everybody's probably scratching their heads and saying, what is he talking about? But if you think about it for a minute, it actually makes sense. And then the definition of Semi-dominant is very close to what you said, Thomas. It is that the phenotype of the heterozygote is intermediate in some way, not exactly in the middle, but in between that of the two homozygotes. Does that make sense to people? So you always, when you say, you don't ever want to write, and it's lots of people make this mistake, you don't ever want to say Marfan syndrome is an autosomal dominant disorder, because that's not correct. Another good example is polycystic kidney disease. Has the exact same attribute as does HBOC, in that the cysts have a second mutation in them. So really it requires the loss of function of that gene product for the disease cyst to manifest. So biologically it's recessive, but genetically the susceptibility, the condition is observed to have the inheritance pattern of autosomal dominant. And there's another dominant form of inheritance. Does anyone know what that is?
RB1, retinoblastoma.
No, but remember, because diseases don't have the attributes of dominant, right? So we're talking about inheritance pattern. What other dominant inheritance patterns are there?
Maybe X-linked?
Co-dominant.
Co-dominant, right? And what's the definition of co-dominant?
That both alleles are expressed at the same time.
Right, and the expression of the alleles is independent of the other allele. Exactly. And there's X-linked dominant and X-linked recessive, which are interesting. That's worth a whole other 20-minute discussion. I actually tell you what, I'll send Don a paper that he can forward to you guys that, in fact, human geneticists don't understand X-linked inheritance at all. It's a mess because it's really complicated by X inactivation. The Morgan's rules of sex-linked inheritance were worked out in fruit flies that don't inactivate their X chromosomes. So it's a completely different concept, but we've sort of bastardized it and we use it even though it doesn't really make sense for human biology. But I'll send that paper around and you can read it and we can talk about it sometime if people have questions.
Great. Thank you for that addition. That was fantastic. Rob, thank you for your presentation. And if there aren't any other questions, we'll sign off for the day. Thanks to everyone.
Thanks, everybody.